After studying this module, you should be able to know about the significance of metallic poisons, some notable metals responsible for significant poisonings and their mechanism of action and action sites in the body. Although most metals occur in nature in rocks, ores, soils, water and air, levels are usually low and widely dispersed. In relation of human exposure and toxicological importance, it is anthropogenic activities that are most significant because they increase the levels of metals at the site of human activities. Metals have been used during the course of much of human history to make utensils, machinery and so on, and mining and smelting supplied metals for these uses. More recently, metals have found a number of uses in industry, agriculture and medicine. These activities have increased exposure not only to metal related occupational workers but also to consumers of the numerous products. Regardless of the comprehensive range of metal toxicity and toxic properties, there are numerous toxicological features that are common to many metals. For a metal to exert its toxicity, it must cross the membrane and enter the cell. Metals form an important but disparate group of agricultural, household and industrial poisons that are present many difficulties in their systematic chemical analysis. Severe acute poisoning with these agents is rare in most developed countries but remains common in many underdeveloped parts of the world. Chronic poisoning, such as a result of occupational or environmental exposure to the heavy metals and pesticides, occur in many countries and can be a cause of ill health in both adults as well as in children. Toxicity of metallic poison may be influenced by the chemical nature of the compound ingested and the route of administration. Inhalation of vapors can cause acute toxicity, including rapid death. The signs and symptoms of acute poisoning may differ from those associated with chronic toxicity. Some metallic substances undergo extensive metabolism after ingestion. These factors have a significant bearing on analytical investigations applied to biological materials and their interpretation. It is important in individual cases, therefore, to know whether poisoning resulted from acute, chronic or acute on chronic exposure. Of equal importance is the time of specimen collection in relation to the alleged time of exposure. Forensic issues. The wide range of metallic poisons that might be involved in any case of suspected poisoning means that great care is required in the collection of appropriate specimens and the selection of toxicological and other tests. There is no simple systematic way to investigate cases for which the history is uncertain and the identity of the poison unknown. The investigation is often led by a process of elimination of the most likely causes of poisoning. For example, pharmaceuticals and illicit drugs, and then a careful examination of the detailed history of the patient or the diseased, in particularly any access to compounds associated with industrial and agricultural use or specific household products. Considerable advances in analytical techniques for measuring metals in biological fluids have been made since the early 1980s. Particularly in the electrothermal atomic absorption spectrometry, considerable advances in the analytical techniques for measuring metals in biological fluids have been made since the early 1980s, particularly in electrothermal atomic absorption spectrometry, inductively coupled with plasma mass spectrometry, which is ICP-MS, and ICP coupled with atomic emission spectrometry, ICP-AES. The use of ICP-MS has expanded rapidly in the past few years, and it is now the technique of choice for sensitive multi-element analysis, particularly in the investigation of suspected poisoning with heavy metals or less common inorganic poisons. Some notable metallic poisons are: number 1, aluminium. Aluminium is the most abundant metal in the earth crust, but its role in biological and medicine became understood only relatively very recently. The normal intake of aluminium from food and beverages is up to 100 mg per day, but its absorption from the gut is relatively poor and depends upon the specification of the element and the presence of other substances, for example, phosphates, in the diet. A number of over-the-counter anti-acid preparations that contain aluminium hydroxide are used widely, which can increase the daily intake by several grams. Incidences of acute aluminium poisonings are relatively uncommon in the normal population. However, those exposed to aluminium through the occupation and patients undergoing certain types of clinical treatment may be at risk. It has been established that excessive exposure in patients undergoing dialysis can cause dialysis dementia, a type of encephalopathy that can be rapidly progressive and lead to death within a few months. Use of aluminium sulfate as a flocculating agent in domestic water supplies is a major source for the metal. These patients, particularly if the water used for dialysis is not purified. The large quantities of oral aluminium salts that may be given to some renal patients to reduce the intestinal absorption of phosphate may also cause toxicity. Concern has been developed as the harmful effects of occupational exposure to aluminium. Where occupational exposure involves inhalation of fine particles or dusts, aluminium may be stored in the lung tissue and leach out very slowly over many months. As a result, the plasma and urine aluminium concentrations can remain elevated for several weeks or months. In such situations of acute or chronic occupational or environmental exposure to aluminium, measurement of blood or plasma or urine aluminium is an effective way to assess the degree of exposure. Let's study about the antimony. Various salts of antimony like tartar emetic, antimony potassium tartrate have a long history of use as medicines and continue to be used as to treat the tropical parasitic diseases such as schistosomiasis and leishmaniasis. Antimony compounds are also used industrially in the manufacture of lead batteries, semiconductors, paints, ceramics, and pewter wares. Other modern industrial compounds include antimony oxychloride, widely used as a fire retardant on fabrics and mattresses. The fatal dose of antimony in the form of tartar emetic is about 1 gram in the adults, but there is much inter-individual variability. The signs and symptoms of acute antimony poisoning include metallic taste, dysphagia, epigastric pains, violent vomiting, diarrhea, abdominal pain, and circulatory collapse. These symptoms are almost indistinguishable from those of acute arsenic poisoning, but larger doses are required. Similarly, the effects of exposure to strychnine are similar to those of arsenic. Chronic effects of occupational antimony exposure include antimony spots on the skin and the pneumoconiosis. There is limited information on the concentration of antimony in blood, urine and tissues in cases of antimony poisoning or in the body fluids of patients who receive antimony containing drugs. Let's study about the barium. The inorganic compounds of barium are widely used as pigments and glazes in industry and in the manufacture of paints, glass and ceramics. The insoluble salts of sulfate is widely used as radiographic contrast medium. Most insoluble barium salts are relatively non-toxic. However, pneumoconiosis related to the inhalation of barium dusts have been recognized in the mining industry. By contrast, the soluble salts of barium, particularly the carbonate and the chloride, are extremely toxic if inhaled orally, if given orally or given intravenously. The oral fatal dose of soluble barium salts may be as little as 0.8 grams. Signs and symptoms of barium poisoning may show within 1 to 2 hours of ingestion and include abdominal pain, diarrhea, vomiting and tingling around the mouth. Severe hyperkalemia may also develop from a shift of extracellular potassium into muscle. This may cause cardiac rhythm disturbances which require close monitoring and the administration of potassium chloride intravenously to correct the hypoglycemia. Other useful investigations in the case of acute barium poisoning include radiography of the abdomen for the presence of radio-opaque material in the gut. In non-fatal cases of barium poisoning, plasma barium concentration of up to 8 mg per liter have been reported. Bismuth. Bismuth, a heavy metal, produces toxicity that can sometimes mimic that associated with lead and mercury. Bismuth salts have been used in medicine for more than 200 years as topical salves and in the treatment of gastrointestinal disorders and are available in over-the-counter preparations. Most orally administered inorganic salts of bismuth, being relatively insoluble in water and poorly absorbed from the gastrointestinal tract, cause minimal toxicity. Other compounds, particularly lipid-soluble organic compounds, are known to accumulate in the body after excessive dosing and can cause severe neurotoxicity such as progressive encephalopathy. Water-soluble compounds of bismuth are more likely to cause renal damage, including oliguria and acute renal failure. A number of deaths have been reported after acute and chronic overdose with various bismuth medicinal products. Measurement of urinary bismuth concentration may be useful diagnostically or after treatment of poisoning using oral chelating agents which can greatly increase urinary clearance of bismuth. Acceptable therapeutic concentration in blood are generally up to the 50 microgram per liter. What is the mechanism of toxicity and the action sites of metals? First is enzyme inhibition or activation. A major site of toxic action for metal is interaction with enzymes resulting in either enzyme inhibition or activation. Two mechanisms are of actual importance. Inhibition may occur as a consequence of interaction between the metal and the sulfhydryl, that is SH group, on the enzyme, or the metal may relocate an essential metal cofactor of the enzyme. Subcellular organelles. Toxic metals may disrupt the structure and the function of a number of organelles. For example, enzymes associated with the endoplasmic reticulum may be inhibited. Metals may be accumulated in the lysosomes. Respiratory enzymes in the mitochondria may be inhibited, and the metal inclusion bodies may be formed in the nucleus. Carcinogenicity. A number of metals have shown to be carcinogenic in humans or animals. Arsenic, certain chromium compounds, and nickel are known for human carcinogens. Beryllium, cadmium are probable human carcinogens. The carcinogenic action in certain cases is thought to result from the interaction of the metallic ion with DNA. Kidney. Because the kidney is the main excretory organ of the body, it is common target organ for metal toxicity. Cadmium and mercury in particular are potent nephrotoxicants. Nervous system. The nervous system is also a common target of toxic metals, particularly organic metal compounds. For example, methyl mercury, because of its lipid soluble, freely crosses the blood-brain barrier and enters the nervous system. By contrast, inorganic mercury compounds, which are more water soluble, are less likely to enter the nervous system and are primarily nephrotoxicants. Endocrine and reproductive effects. Because the male and female reproductive organs are under the complex neuroendocrine and hormonal control, any toxicant that alters any of these processes can affect the reproductive system. In addition, metals can act directly on the sex organs. Cadmium is known to produce testicular injury after acute exposure, and lead accumulation in the testes is associated with testicular degeneration, inhibition of spermatogenesis, and lytic cell atrophy. Respiratory system. Occupational exposure to metals in form of metal dust makes the respiratory system a likely target. Acute exposure may cause irritations and inflammation of the respiratory tract, whereas chronic exposure may result in fibrosis or carcinogenesis because of arsenic, chromium, or nickel. Let's summarize what we have studied. Metals form an important but disparate group of agricultural, household, and industrial poisons that present many difficulties in their systematic chemical analysis. Metals are essential in the diet but are toxic at the higher doses. Thus, iron, copper, magnesium, cobalt, manganese, and zinc can be present in the diet at low level, that is deficiency, at an appropriate level, that is maintenance, or at the too high, that is toxic. For a metal to exert its toxicity, it must cross the membrane and enter the cell. If the metal is in a lipid soluble form, such as methyl mercury, it readily penetrates the membrane. The wide range of metallic or anionic poisons that might be involved in any case of suspected poisoning means that great care is required in the collection of appropriate specimens and the selection of toxicological and other tests. The toxicity of metallic poisons may be influenced by the chemical nature of the compounds ingested and the route of administration. Inhalation of vapors can cause acute toxicity, including rapid death. Considerable advances in analytical techniques for measuring metals in biological fluids have been made since the early 1980s, particularly in the electrothermal atomic absorption spectrometry, inductively coupled plasma mass spectrometry, and ICP coupled with the atomic emission spectrometry.